Okay, so today it's very important when we ventilate a baby to monitor. So we monitor the saturation, we monitor also by X-ray or by ultrasound, we do blood gas, we monitor clinically, we score the pain, okay? And we do non-invasive blood gas monitoring, such as transcutaneous oxygen and transcutaneous CO2, end-tidal CO2, capnography, or calorography, all can check the CO2 level. So as we've discussed in the ventilation and respiration monitoring in the first session. But one very important monitoring is looking at the numbers, the dependent conditional variables, and we can also change these numbers to graph. The importance of these numbers as a table or as a graph, it will show us the trend, the changes between one breathing, one breath, and the other. So it shows us the trend. And the graphs or graphics are very important because they are continuous and non-invasive and shows the trend, the changes over time. So it's very important of somebody ventilating, an intensivist or a nurse, is to understand how to look and when it's alarming and when you interfere. So when we look at the ventilator, we have a biological signal coming from the patient. The instrument respond to this signal. We calibrate so the numbers on the instrument look like the standard that we know. And at the same time, the monitor filter this signal to remove any artifact and noise, and then process it. And once it's processed, it can provide it as analog or it can provide as a digital. Once when it goes analysis, the analysis, it measure it as a numbers or graphics, and then we interpret it. Okay? So the graphics is a pulmonary value, a pulmonary parameter versus time. Some of you contact me and they ask me for something. And then I say, what do you want? Do you want this? You say, as you like. As you like? You're contacting me, ask me for something. You have to tell me what exactly you want. I like to continue, of course. So these parameters can be pressure, can be volume, can be flow. And as I said, because it shows us more than one value, more than one breath, between 3 and 7 at a time, it can tell us the trend. But also, because it shows the type of the breath, it also shows the type of the control, whether it's a volume or pressure. And also it shows the response of the baby. So in short, it can tell us the control, and it can also tell us the mode. And also it can show us whether the ventilator and the baby working in harmony in organized orchestra, or they are not. So it can tell us the synchronization. Okay, now we have something built in called flow sensor. It's composed of platinum or tungsten or platinum iridium. It's a wire, and this wire in the center of a sensor. And the sensor are heated to a fixed temperature. Once the gas flow over the wire, it cool it down. However, the sensor are provided with electricity to return it back to its original temperature. So flow, cooling, temperature, heating, and then the amount of the current that is needed to return the sensor to its original temperature can be measured, and we can convert it to flow. And once we measure the flow over time, we get the volume, And once we measure the speed of the flow, we get the pressure. Any question about this? And as we said, when we receive the signaling, the flow sensor will start measure and also remove the noise. And that's always we need to calibrate the sensor, as we said, to make the measurement of sense. Any question? It's very important that you understand what I'm telling you. Okay? So if you have a question, please stop me. Now, if you want to measure the flow in and out, we use 2 wires. So it can measure a flow sensor of 2 wires. So we can measure both inspiratory and expiratory pressure. And the transducer or the flow sensor can be inside the ventilator, but also it can be in the tubing, somewhere in proximity to the patient. The sensor, if it's outside, it's a little bit more accurate. So if you can see here that we have 3 types of graphics. We have, and this is the standard on the screen. We see on at the top we see the pressure, and in the middle we see the flow, and on the lower way we see the volume. Now the most important is the flow. You can see also here you have the set values or independent conditional parameters, and some of them are phase parameters. And you can see here the measured or the dependent conditional parameters, and you can see here is the graph. So we have numbers of 2 types, and we have the graph. Now the problem of the or the limitation of the graphs are the following: scaling. And if you guys don't understand what scaling is, the size of the graph on the screen. Do you make it small or you make it large? So the larger you see better, but you will see less number. So scaling, is it flow clockwise or anti-clockwise? So sometimes can be clockwise, can be anti-clockwise. So it's a little bit confusing depending on the ventilator. Now also there is no reference value. And that's why the trend are important. So we cannot look at one breath and say, oh, the tidal volume is high. Because there is no reference. Well, you don't know what is high, what is not, what's wrong, what's correct. However, even if it's wrong, the trend changing will give us, will give us some. There is interpatient, between patient and patient, variability. And also there is intra-patient, same patient of different time, there is variability. Any question? It's vital to ask question if you don't understand. The graph measure the mechanics. It does not measure the function. And we say function here, we mean gas exchange. So it does not measure the oxygen and the carbon dioxide or ventilation. It measures only the mechanics, the pressure, the flow, the volume, the interaction, and it affected by the compliance and resistance. Now the ventilator assume the leak is 0. There are few assumptions that you will learn with time. When the ventilator starts to ventilate a patient, it assumes that the leak is 0. And the outside pressure is 0. So the atmospheric pressure, which is 760, it assumes that it is 0, and the leak is 0. And as you know, we don't use cuff tube in small babies because of the damage on the recurrent laryngeal nerve and other injuries. So whenever you use uncuffed tube, there is some percentage of leak. And when you have a leak, 10 or 20, some of the ventilator can compensate for that leak. However, that leak will affect the graphics and loops. So the graphics are very important when you see something wrong to look if there is leak or not. So the loops are graphics, both of them are continuous, non-invasive, shows the trend, shows the dynamic, and they are instant. There is no delay between what you see and the real life. Now, as you said, that there are 3 types of graphics, and they are pressure, volume, and flow. The flow is measured by mil/second, the volume is measured by mil, and the pressure is measured by the centimeter water. It also shows us the phase variable, the change over time. So you can look at the point A, it tells us that the ventilation started, the inspiration started. And point B, it tells us that this is peak inspiration. And point C, this is the end of inspiration. And point C is the start of expiration, and point D is the end of expiration. Any question? It's very important that you understand. So if you don't understand, please ask questions. Okay. Now, if you look that some ventilator, they show you 2 colors. There is 2 colors, okay? The one color is the patient contribution, and the other color is the machine contribution. It's very important because sometimes it's so difficult, and that will make life easy, because if there is no contribution, this is mandatory breath, and if it's mixed contribution, it's assisted breath, and if there is only patient color, is a spontaneous breath. So this is the advance of some ventilators. It shows in color. Okay, now is that clear? Is that clear?
Yes, Doctor.
Okay, now looking at this value, this volume, what is the control that you think is here? Is it pressure control? Is it volume control, and why? Another question. If we ignore this, the one below, is this, if this breathing, if this breath, is it assisted? Is it spontaneous, or is it mandatory? Nobody's answering?
It's mandatory, Doctor, I think.
It's mandatory, you think?
Yes.
Why?
It's regular. It's regular between
It's regular,
each
huh? It's the same.
Yes.
Yeah,
Yes,
it's
the
a good
same.
thought. It's the same.
Yes.
It's a good thought. Okay. Any other opinion? It's very important that you start discussing, because by discussing you will learn. You don't need to shy or hide.
And because it's
So
pressure control, because there is no plateau.
ماذا أسمع؟
It's pressure control, not volume control, because there is no plateau phase.
ماذا أسمع زين، يعني سمعت كلام هيك خفيف، بس ما مركز انت شو تقولين لأن صوتك خفيف.
It is pressure
So is it
control.
volume or pressure control?
It's pressure because there is no plateau.
Plateau where?
There is no plateau.
Correct. So mostly this is a pressure control because the volume are peak.
Pressure. Yes.
There is no plateau, there is no
Yeah.
sustain of the volume. Yeah, that's acceptable. But assuming this is not existing, what do you think the breath types? Is it mandatory? Is it spontaneous? Or is it assisted, and why? The other doctor said they are the same shape, so probably they are mandatory. What do you think? Now, if you look here, you can see this notch. You see this notch? You guys see this notch? You can see it here also.
Yes.
This is
Yes.
trigger. So all these breaths are assisted. The first because they are look like, so they are contributed by the machine. Okay, because they are the same. But you can see here there is a trigger. And in this advance, you can see two colors. You can see the patient contribution and then the machine. So patient, machine, patient, machine, patient, machine. And almost the patient achieve almost like 90% of the volume. So these are assisted. So if it's assisted, what type of mode do you think mostly? What type of the modes that have assisted breaths according to yesterday's session?
AC mode, doctor. AC.
Which mode has assisted breath? No contribution, no opinion? Just say something.
AC mode, doctor.
AC mode has assisted, yes. What else? PSV mode has assisted, right? Right?
Yes.
So
yes.
this is either AC or
Or
PSV. Because if it's intermittent, no spontaneous at all, because if it's SIMV, there will be no assisted. There will be either a spontaneous, non-assisted, or mandatory. So
I
definitely
think
this
it's
is
PSV mode. This is
can be PSV, it can
because
be
PSV.
AC, and it can be also SIMV in sedated patients. Because SIMV also synchronize with the patient. So SIMV or as SIMV in a sedated patient. Here's that. So it can be SIMV if the patient is severely sedated. And you said it's PSV. Why it's PSV?
Because in PSV only there's assisted waves.
Yeah, it can be assisted. It can be AC. It can be PSV. Both. But we cannot differentiate based on this volume only whether it's PSV or it's AC, because I will show you later. So you can see A, B, C, and D.
But in AC
Okay.
there is control also. There is mandatory also.
There is no mandatory. Do you see mandatory? There is none.
No,
All
no,
it's
not in
contributed.
this one. I mean in AC mode, there is mandatory waves also.
There is mandatory and there is assisted, right? But if the patient
Yes,
is
both.
breathing above the rate, you will not see the mandatory, right? Because if you set it at 30 and the patient is breathing 40, you will not see the mandatory, right?
Yes,
You will
yes,
see only
exactly.
assisted. Unless
Right.
the patient breathes 29, you'll see one mandatory. If the patient is 28, you'll see two mandatories in 1 minute, correct? But if the patient, you set it at 30 and the patient is breathing 40, you will never see mandatory.
Okay.
You'll see only the assisted, because the assisted are more than the set, the backup rate, right?
Yes.
Do you understand?
Yes, doctor.
Okay, do you understand?
Yes, yes, doctor. Yes.
Just talk to me, huh?
Yes.
Now, we can see the pressure. Look at the pressure now. So we have the PEEP, we have the PIP, and we have the shaded area, which represent the mean airway pressure. Okay, we have the start, we have the end, and we have also the control. So we can see the pressure is rising up suddenly. Okay, so what type of control is this? Because remember, we said the pressure is the speed of flow, how fast the flow is. So you can see going right up and achieving the pressure and then staying there and then going right down. Okay, so this is, and you can see in the flow, it goes right away. It never stays. So this is not volume. This is pressure control. So this is pressure control. Okay, and you can see it's all of it is assisted. So it's a pressure control, most likely AAC or PSV. So we have volume and we have the pressure. Now we have to see the flow to understand. Okay. So there is inspiratory hold is used to prolong the inspiratory time, preventing exhalation valve from opening. A plateau pressure may develop. So you can see the pressure, the plateau. So this is a pressure control. Now we look to the volume and we look to the pressure. So is this volume control or pressure control?
This one, there is a plateau phase.
Yes. And you can see
So
the volume
there
is
is,
building. Okay. And the
yes,
pressure is plateauing. So this is a pressure control.
yes.
Okay. So pressure control is just you tell the machine to hold the valve, not opening it, and the pressure will build. So that will be the pressure control. There is something called pressure overshoot. In pressure control and pressure support ventilation, we use the time, the speed of time. So we utilize the acceleration and deceleration of the flow to achieve the pressure. If the flow is set too high, it goes up and then go down. It goes up and then go down. And that's what we call it pressure overshoot. So if you see that, mean the timing of the rising of the flow is higher than the accepted, need to go down. So that's we call it pressure overshoot, or some people call it ringing. There is a notch in the pressure wave. And you'll see two peak of the PIP, the PIP. So in that situation, the rising time, the ramp should be corrected. And usually the rising time is 1/3 of inspiratory time. So if you make the inspiratory time, let's say 0.38 second, then the rising time probably 0.12 or 0.13. Okay? And if you look at the flow, you can see how fast going and then go down. Okay? So you can see the rising time between the starting point and the maximum point that's what we call it, the rising time. So if the rising time is too high and then goes down, you'll have overshoot. And remember, the flow is very important. And the flow starts from 0, this white line, and it should always go back to 0. So if it does not start from 0 and it does not go back to 0, then something wrong. So the starting here should start from 0, coming back to 0 before starting here, and coming back to 0 before starting here. If it does not start as 0 and it does not goes back to 0, there is a problem. So to solve this, either you increase the rising time or decrease the flow in the ventilator. Some of the ventilator, they are auto-adjusted for pressure overshoot. Do you understand the pressure overshoot? So the flow waves, the flow graphics are very important. It's more important than the volume, and it's more important than pressure wave. It is the corner of the graphics. You need to look at it. And with time, you'll understand. Look at the flow wave. It is the most complex. It should be 0. If it's 0, then the gas is not moving in and out. It's a pause. So you have A, the acceleration phase of inspiratory flow. You have B, the deceleration. You have D, the acceleration of expiratory flow. So you have acceleration of inspiratory flow. You have the deceleration of inspiratory flow. You have the acceleration of expiratory flow. You have the deceleration of expiratory flow. And then you have the end of expiration. Any question about this? It's very important to understand. Should be 0, and it's a little bit more complex. It's 3 phases of each: acceleration, inspiratory flow; deceleration, inspiratory flow; acceleration of expiratory flow; deceleration of expiratory flow; end of expiration. Clear?
Sorry, doctor. Can you show us a graph of volume control also to know the
You'll
exact
see.
difference
No, you'll see.
between?
We didn't talk about the control yet. I was just asking. I was just showing you I showed you the volume graphics, the pressure graphics, and now I'm showing you the flow graphics. But you will see each mode, you'll see the flow of everything. Each complication you'll see. But right now, I've talked about overshoot, but I was only trying to show you the flow, the pressure, the volume, the graph itself, the principle of the graph. And now we're talking about the flow of the graph. But we will see the you will see
Volume.
the different type of graphics in different modes and in different complications and how to solve it.
Okay, thank you.
Okay. Now the flow are of 2 types: either the hold, there is hold, or we call it constant, or there is no hold. Once there is no hold, it will be variable, going up and down, not down. So when there is hold of the flow, is it volume or pressure control? When you take time in the flow, you give you pressure or volume?
Volume. It takes
Volume.
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 Once you need to inflate a balloon, you need time. Remember that. But if you want to blow a feather or a paper, you need to blow very strong to make it flying, to give you pressure. So when you see a hold, once you see a hold, then this is volume. If you see variable going up and down, then it's either pressure control or pressure support ventilation. And remember, it should start 0 and go back to 0. If it does not, even if you don't understand, there is a problem. This is about the flow graphics. Question? is there is a hold here. Is there is a hold? Do you think that there is a hold?
Yes, there is hold.
Yeah, so this is
Yes.
volume control. Okay, it's very important to remember that there is hold here. But the good news, it goes back to zero. But if you can see, it goes back to zero, but never pause, goes right away to expiratory phase. And that's not good because the baby is breathing in and then right away out. There is no pause, there is no wait. So this is not good. Here is not good. But here is good. Here is good. Here is not good. There is no pause here. There is something wrong here. Now, when there is increased expiratory resistance, what will happen? Because once you inspirate, the air goes in. And if you remember the asthma, when you have bronchospasm, where and when you hear the expiratory prolonged, which one is prolonged, and when you hear the sound? Is it inspiration or expiration?
It's expiration.
It's expiratory problem. So when there is expiratory problem, there is airway problem. Okay? So when you look here at the beginning of expiration and end of expiration and the maximum expiration, you see short. And you can see here is the time is doubling. So you have either longer expiratory acceleration or longer expiratory deceleration. So it's very important to remember that. Expiratory acceleration, expiratory deceleration. So this is in a small airway and this is in the large airway. We will learn that with time. But remember, this is inspiration, mainly affected by the alveoli, and this is the expiration, mainly affected by airway. And sometimes we see both. So you can see here short inspiratory and short inspiratory and short expiratory. Is that clear? Prolonged expiratory phase, meaning increased respiratory resistance. Because remember, resistance is airway, compliance is alveoli. Do you understand this?
Yes.
Okay. Now, what is wrong here? What is the difference between here and here? It's here return to the baseline. Remember with the principle? It always has to go back. But here, is it returning to the baseline?
No,
No.
not returning.
It start the inspiratory have some positivity. It's longer than the needed. It's so from where this longer needed? Because air is from previous. Air is remaining from the previous cycle because the previous has to go back to zero, like here. And it starts before it returned to zero. So there is air from the previous cycle. And that's the air trapping. Okay, this is air trapping based on the flow graphic. So if you see this, that means the air is trapping. And if air trapping, what does that mean? Which diseases cause you air trapping?
Pneumothorax.
Which disease cause you air trapping?
Pneumothorax.
No, pneumothorax does
Emphysema.
not cause you leak.
COPD diye doktor.
Sorry, again?
COPD.
Yes.
What's COPD? Sorry, I don't know.
Chronic obstructive pulmonary.
My goodness, chronic obstructive is an adult problem. We don't see it very common. Just what's more common? You see it every day.
It's pneumonia. Pneumonia.
Not pneumonia.
Bronchiolitis.
Asthma.
Huh?
In atelectasis also.
Dr. Foreign body,
Why going to rare diseases?
bronchiolitis,
Most
bronchiolitis.
common disease you see. Bronchiolitis and asthma.
Asthma.
Yes.
Yes.
Yeah, this is the most common. Right? And in neonate, when you see air trapping in neonate,
RDS.
meconium aspiration syndrome and chronic lung disease. Okay, so this usually you see it asthma, bronchiolitis if you are a child, and you see it in chronic lung disease, baby ventilated for a long time, or you see it also in meconium aspiration syndrome. And how you fix this? How you fix it? You give more time for the expiration to go back to zero. So you need to push this a little bit away. How you do that? By prolonging expiratory time or giving a bronchodilator. Is that clear? Question?
Yes, it's clear.
Question? You can also do it by shortening inspiratory time, but that's not a good. So you can prolong expiratory time, you can shorten the inspiratory time, and you can also decrease the rate. All will achieve you the same. But we don't want to decrease the rate if you have normal CO2. And you don't need to shorten the time because you cause dryness of the airway because the baby start to be thin and baby will not be comfortable. So the best solution is to prolong expiratory time. But you can do it all. It can solve the problem. Remember, it should start from zero, not like here, starting from below, and it should go back to zero. And that's what we call it air trapping. Is that clear? Guys,
Yes.
talk to me, please. It's interactive slide. You have to talk to me. You have to, don't come in the clinical session and you forget everything because you're not talking. You should talk to me because I stop giving online if you don't talk to me. I will always do it clinical because I need you to talk to me and you repeat it until you memorize it. It's very important that you memorize it. So please talk to me.
Yes,
Okay,
doctor. It's
cycling.
clear.
Repeat.
Yes, it's clear, I
Want me to
said.
repeat?
Sorry, doctor. No, it's clear.
Sorry?
Thanks.
It's very
It's
clear.
clear,
Okay.
doctor. Yes.
Cycling. What is cycling? If you remember, cycling is the transition of inspiration to expiration and then expiration to inspiration. So inspiration, expiration, expiration, inspiration. The cycling can be time. Okay. And when it's time, it's usually fixed time. And the good time is when you see there is pause before, pause below, after, normal CO2, good oxygenation, patient is not fighting. That is very good inspiratory time. So remember, the flow has to go back to zero and start from zero. However, this pause should not be prolonged. The reason, because baby start in and then baby want to start out and then there is a hole. The machine is not allowing, so it will not be comfortable. So if you prolong this, you can see baby breathing in and then he has to hold and then expirate. Okay, and also you cannot make it right away. So there is a little bit of pause, but should not be prolonged pause when there is no flow between inspiration and expiration. Is that clear? Because the baby breathe in, the valve is closing, you want to breathe out, the valve is not allowing, there is pause then. So the pause, this pause is very important. So you play with the inspiratory time and the expiratory time, or the ratio between inspiratory and expiratory, and the rate, until you see this. Not long, but not zero. And that's mean the hold between inspiration and expiration is comfortable for the patient. Is that clear?
Doctor, a question. How we know on the ventilator that the hold is it's okay, it's normal?
I don't hear you. Yeah.
how we know on the ventilator that this hold is okay for the baby, it's normal.
As I told you, it should not be zero, so going right away, and it should not be prolonged, and the baby is comfortable. The baby is happy not ventilating. You don't need sedation, and when the baby needs sedation, he will start not bleeding, he start moving. Okay, you don't need much of sedation. You can decrease. Once the baby is unsedated, and then the nurse comes and tells you, okay, doctor, the baby need more sedation. He's not okay, and the baby ventilated, and you come and you see pause. Probably you need to decrease this pause, and if the baby start to be comfortable, then this is appropriate pause for him or her. Because I didn't hear you very well, that's why I don't know if I answered the question.
Okay, that's great. Tamam.
Okay. So we also have a flow cycling. Remember, we have time cycling. So we tell the patient, the machine, give 0.3 second as inspiration, pause 0.1 second, and give 0.6 second for expiration, and then pause and then start. So time, we tell different time, different phases. That's what we call it, time cycling or phase variable. We also have flow cycling. So there is microprocessor control the ventilation. We can use it in pressure limited ventilation. So we have volume control, but pressure limited. We will learn that in future. We can use it in pressure control ventilation, and we can use it in PSV. So the transition between inspiration and expiration, the difference between the flow and time cycling, the flow is natural. The ventilator check the peak inspiratory flow, then check the deceleration. So check the peak and then check the deceleration. Before it reaches zero, at a point determined by the ventilator algorithm and the clinician set it, usually it's 5 to 25% before zero, and then the next breath started. So there is the machine measure the peak, and usually it give it 100%. And then once there is deceleration, there will be remaining before the percentage remaining to go down to zero from the peak. So the machine measure the peak and then measure the decreasing or the deceleration. And once start from a point determined by the machine and or the clinician, because some of ventilator is self-determined, and usually it's between 5 to 25 remaining. And then the next breath start from this determination. And therefore, because of that, it's 100% synchronized. There is synchrony between the patient and the baby. And because of that, it's not controlled. We are not where the baby will never start before it goes to zero, because it measures the remaining, and therefore it will never have air trapping. Because remember, in time cycling, it's regardless what patient want. There is time need to be finished before the transition happen. While in this, it controlled by the baby, because it depends on the flow. It depends on the percentage of remaining flow. And therefore, the patient can clear the air, because he can prolong the inspiration as much as he or she wants, and it's up to, it can inverse. It can make the inspiration shorter than the inspiration, can be the same, and can be prolonged. The problem with that, if the baby have tachypnea and moving or breathing very fast, because once they breathe fast, because he is driving the ventilator, we will shorten the inspiratory time. So that's only true that trapping will not happen when there is no tachypnea. So whenever there is tachypnea, especially more than 60, you need either to sedate the baby You need either to sedate the baby or switch the mode from PSV to another mode to prevent air trapping in PSV if there is. So PSV more than 60 is not good. Clear? Now let's look at the deceleration. Look at this. You can see the machine started and it's 50%. Check again, it's 75%. Check again, it's less than 25%. So you can see here, it only supports the baby by 50%. Here, support the baby by 75%. And here, only 5%. So it's always measured. So you can see here is 50%, gave more, become more, gave less. So it's always measure the previous cycle and help the baby with the next cycle. Now when there is leak, okay? Now remember the principle, it always has to come back to zero, correct? Do you remember this principle?
Yes.
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 The other principle, in has to equal out. If the in is less than the out, what do you think happening? The air has to come out somewhere.
Air trapping. Air trapping.
So, right? So you are losing the air somewhere.
Yes.
So when this longer than this, you are losing the air somewhere. And that's mean we have leak. So the principle one always has to come back to zero. Principle two, the flow, the in has to equal out. The above has to equal below. The positive has to equal the negative. Is that clear?
Yes.
So whenever is not equal, if the flow in less than out, the out is more than the flow. From where this out coming? Air trapping, correct? Because the out is more than in. From where is this the out coming? There should be received from somewhere. That's mean air trapping. If the in is more than the out, then there is something coming to the in. There is air trapping. There is or the air is lost somewhere, and that's mean there is leak. Is that clear, or I confused you?
Can you please repeat, dear doctor?
So it always has to go back to zero.
Yes.
And the in equal out.
Yes.
If it's not coming to zero and you don't understand, call somebody understand. And if they are not equal on both sides, there is something wrong, call somebody. Is that difficult?
No, it's clear.
So if the in more than the out, where is the remaining of the in? Where is the remaining going? It has to be
It is-
lost from the ventilator. So there should be leak.
Yeah.
Is that clear?
Yes.
If the out more than in, from where this out coming? There should be air trapping.
Trapping somewhere.
Yeah. Is that clear?
Yes, yes, it's clear.
There is something called auto-cycling, auto-triggering, very important to recognize. So if you can see that we set a trigger so the baby initiate and the ventilator continue. And you remember the trigger, the machine measure the in and out, and if there is no difference, there is no trigger. But if there is difference between the in and out, remember they have to be equal, then there is a trigger. And the trigger is coming from the patient. However, sometimes the difference is due to leak. So when you leak, there is a difference. If the leak is more than the set trigger, then the machine will think that this is a trigger because that's a difference. So remember, if the difference, artificial difference, not the patient difference, between the in and out is more than the threshold, more than the trigger, the machine will think that this is the trigger. So if this difference is from the circuit or from the humidifier or from the ETT and there is leak, the machine will think that this is a trigger and will start to shoot very frequently, auto-cycling, independent of the patient. So they will start like high frequency. So remember, this is called auto-triggering. Now, the humidity of the tubing is only on the expiratory arm, not the inspiratory. And if it's high, if there is the trubber, the fluid trubber of the circuit, of the ventilator proofing, is not in the dependent area, because sometimes the nurses confuse and don't make the fluid trapper of the circuit at the dependent area, become independent area, and the tube, part of the tube, become the dependent. Fluid accumulate in that, and the nurse does not look at it, and that also cause the rain out, we call it, and that's called back and forth movement of the fluid and cause auto cycling. So when you see auto cycling, please look at the leak, at the ventilator, at the endotracheal tube, or at the humidifier. And if everything is wrong, look at the fluid in the expiratory arm of the ventilator tubing to make sure that there is no auto cycling. And auto cycling, the ventilator will think that the patient is triggering. When it happened when the leak or the movement of the rain out is more than the set trigger, and therefore the ventilator think that the patient won't breathing, and thus become auto cycle or ventilation of the baby without the need of the baby. And because they become very rapid, then you will wash CO2, and once you wash CO2, you cause hypocarbia, and once you cause hypocarbia, you cause less flow to the brain, and you cause PVL and brain damage. Because it's frequent, you might cause lung injury too. Clear? Now this will never happen when you are time cycle. No, it will happen in time cycle. Sorry, it will happen in time cycle too. Now let's look at the shape of the flow. So this is called sinusoidal. When there is a hold, there is round. And usually when there is round, it's a pressure limited. But also it can be volume controlled ventilation. So pressure limited ventilation and volume control. Because once you control, it can be volume control, but it can be pressure limited. And the difference, we will learn about it in future when you have adjunct ventilation. Anyhow, when you have a hold in the flow, that's mean a volume. And it's very clear that you can see this shape is different from this shape. But however, you can see that in this way, the exhalation going right away to the inhalation, going right away to exhalation. So there is no pause in between, the first. And second, the in is more than out. And the reason because, why the in is more than out? Here?
There is leaking. There is leaking.
No, there is no leak here. There is no leak here. Because we want to achieve the volume. Once the volume, desired volume achieved, they will become the same. Okay, so remember, while you can see here, it goes up and down, never stay. This is pressure control. This is volume control, pressure limit. So this is pressure limited again. So you can see rapid rising, but it's volume control, continue, and then goes down. So usually if it's volume control, but not pressure limited, it will take time to go up, it will hold, and takes time to go down. So you can see this is very short rising time, this is very slow rising time. And you can see here also pressure limited. Okay, now look at the IMV. Why this is IMV? Anybody can answer me? Why it's intermittent mandatory ventilation? Anybody? It's mandatory because it's the same, no change. Second, you can see there is wave and the patient is breathing, but there is nothing here. So it's not synchronized. Okay? You can see the patient breathing here, but it's not synchronized, so it's not SIMV, it's an IMV. And it's only mandatory. You see, it's only mandatory. So this is IMV ventilation. When you see the patient trigger, you see it in SIMV because it should be synchronized. So whenever the patient trigger, it will synchronize it with the intermittent, with the mandatory ventilation, but it will not support it. But it will never breathe against it. So only timing it with, and if the not time, or if the rate exceed, it will not support, but it will not breathe against it. In assisted control, it should be triggered, and PSV. So these are called patient trigger ventilation, SIMV, assisted control, and PSV. Now, what about SIMV? Why this is SIMV? Anybody can tell me? So it's only mandatory, there is not assisted, but they never give a breathing against the patient. It's always synchronized with the patient. You see? Always synchronized with the patient. Okay? So you can see this is colored graphics. So the machine and the patient. So you can see the patient effort and the machine will never breathe against the baby, will never support a breath. So the baby is breathing in and the machine giving out. So it's always synchronized with the patient. In mandatory, of course, you will see the spontaneous and you will see the mandatory. You will never see assisted. You can see it's all one color. You see it's all one color. You see it's all one color. You see it's all one color. Now you look at here, you can see some are supported and some not supported. Okay. Okay, I'll finish soon because we only talked about graphics today. Usually I give graphics and loops at the same time. But when we take clinical, you will learn more. So again, this is assisted control because you can see PSV. This is a graph of PSV. It's a flow cycle. This is combination of PSV and SIMV. I will teach you that later. Very important about the map, it's below the color. So when the map is when the map is low and you want to increase the map, you need to change these. So if you want to change A, which is the rising time, you will get high map. If you want to change the B, which is the peak pressure, you will get more map. If you want to change the C, which is the inspiratory time, you get more map. If you want to change the PEEP, you'll get more map. And if you increase the rate by decreasing the expiratory time, you'll get more map. Inspiratory hold, I will teach you that later. And the trend. So you can see the screen show you the trend over 4-6 hours, and it can show you as a table. So we can see that we were very stable and we start to lose the tidal volume. So that's when I come in the morning, I check the last 12 hours of the ventilation, and then we discuss what's the problem in the morning. So you can see here is the trend, show you the surfactant administration. We'll talk about this surfactant. So you can see the C dynamic change. We'll talk about C dynamic later. We can see the peak flow change because it's increased once we give surfactant. Leak, we talked about leak. This is turbulence of flow. You can see so like Minshar, and that's mean there is fluid turbulence. And I am done. It's not easy, but we'll take clinical. At least you know the terms, and then we will start learning. Any question?
Thank you, dear
So
doctor.
let's stop recording.